Thank you for that kind introduction. It is my distinct pleasure to be here today and to get to share the stage, at least for a little while, with such an esteemed group. And it is my task to try and help moderate this discussion. And I know from having been at camp, though you didn't see my picture up there, that there are just so many questions out there. And this is a highly valuable experience to be able to ask them of such a diverse and knowledgeable group. So I will do my best. A couple things is there will be people in the audience bringing microphones to you. So if you can wait a moment for the microphone to arrive before asking your question, that would be great. If not, then just belt it out. We'll let you know if we can't hear you. I also have several questions that have been written on the note cards. I want to make sure we get to those as well in the time that we have. So I'll intersperse those amongst your questions. And lastly, though, perhaps most importantly, is that the relationship that you have with your physician, if you are a patient, is most valuable. They know you best. They will be able to work with you on your particular issues. So though we welcome your questions today, we want to make sure that you know that we are just answering them with little information that we have, and that really any treatment decisions should be made with your neurologist at home. With that, I'd like to start with a timely question that came on a note card, which is a general question. Are there any problems with flu shots? And I think this is a great question. So are there any of our panelists who would like to tackle this one?
That's a pretty broad question. Are there any problems with flu shots?
I'm imagining it's pertinent to TM.
The short question would be yes. I mean, but I think the question really is, should you get the flu shot, right? Is that what the question was? Probably. We answered the question at the last symposium, and I remember specifically how we've done this, because we actually went from left to right or right to left and see how you all answered it to your patients. My answer in general is to patients that, yes, I would like to have everybody who had transverse myelitis to actually get their annual flu shot, with the caveat that if we think that your transverse myelitis may have been linked to a flu vaccination, then not to go for it. I'll start with Doug here, and then we're going to go over. How about
that? For those of you who don't know me, I'm Doug Kerr. I'm a neurologist. I started at Johns Hopkins. I'm no longer there. I'm working at a biotechnology company in Cambridge, Massachusetts called Biogen, trying to develop drugs for rare disorders. So you know this, but we first started this in 1999. And so we've had them essentially every other year since 1999. So it's great to be back and see this one. I would say get the flu shot. I mean, I think getting the flu for somebody with transverse myelitis is bad. I mean, getting the flu for anybody is bad, but getting the flu for somebody who has some degree of respiratory impairment or has a decreased ability to move their chest wall, the flu could be really bad. I think that there are very, very rare cases where people think that there has been a link between a vaccine. I think most of the time that's probably not so. It's tough to know on an individual basis, but I think it's important to get the flu vaccine, any vaccine.
I agree. It's a good idea to get the vaccine unless you've had a reaction to it in the past. In that case, just hang around other people who've gotten the vaccine so that you're protected.
So I agree. And to add to it, there is no CDC recorded cases or association between TM and the flu vaccines. That's not the truth for GBS. For Guillain-Barré is associated with the flu shot, but as it is concerning CDC, there is no association between TM and the flu shot.
Does somebody from the audience want to pose a question? Okay, how about here in the front in the green shirt?
All that I have read about NMO is it is caused from a vaccine or a vaccination.
Okay.
Any research I've done, that's what I've found. And they contribute my case to a vaccination.
Okay, I think that's a really important question to tackle. Just for folks who might not have heard the question, it was about neuromyelitis optica, NMO, and the known triggers for this disorder. Is there someone on our panelists who would like to tackle that?
So with NMO, your immune system is primed to attack over and over and over again, and all it needs is a trigger. The vaccines do activate your whole immune system, and then in doing so, it can also activate the bad part of the immune system that can cause an attack. Still, if you have NMO and you've never had a reaction to a vaccine in the past, we still recommend it because the flu itself can also activate your whole immune system and trigger an attack. So it's a balance of risks, and on the whole, again, if you've never had a reaction, we do recommend the vaccine.
But Mike, can I qualify that answer with one comment? Because I think it's important to separate out causation and triggers. And Mike, please edit if I'm reading into what you're saying. In the setting of NMO, at least the data I've seen does not suggest that the vaccine caused the disease. That we have patients who have this antibody, an anti-aquaporin 4 antibody that's common in patients with neuromyelitis optica. And there are patients who we have found evidence that they've had the antibody in their system for over a decade with no attacks. And then one day they have an attack. So why on a Wednesday at 3:30 do they have the attack? I don't know. Maybe it was the cheeseburger they ate at lunch. I have no clue. Is vaccine on the list of possible, cheeseburger, infection, vaccine? Sure. They're all on the list of possible triggers that lead to it. So I think there's data to suggest that a vaccine could prime a pre-existing autoimmune disease, but that's different than actually causing the disease. So is that?
That's very accurate. Yeah.
Okay.
Okay. Sorry. I'll repeat one question that was submitted on a card, which I think is an important thing to talk about, a symptom of transverse myelitis, the band around the chest, and whether anything can be done for treatment of that. So we've heard from Dr. Graves about some symptomatic treatments. I don't know if you'd like to start us off.
So I've tried a number of the medications that we use for neuropathic type pain for that symptom. So a lot of people with transverse myelitis inflammation in the spinal cord will have this banding tightness, like a squeezing around their chest or abdomen, and oftentimes very painful. And there's a list of these medicines. We don't really have a talk scheduled on pain management in these diseases, but we oftentimes use a lot of the anti-seizure medicines, like I mentioned, for spasticity. There's a number of antidepressants that we use for that type of pain, and those can be effective. I don't know if there's other.
Have you tried medical marijuana?
Not personally, no. So there also are a number of studies looking at marijuana for pain relief, and there is some evidence there, kind of mixed again.
I'm going to repeat the question, Sandy, just so it's everybody can hear. Is that about what causes this sensation of banding? Is it because of spasticity in the chest or a sensory disturbance?
I believe it's both. And the reason is, remember, the network of sensation is intimately associated with other networks in the spinal cord. So when there is a problem with a very focal lesion in the spinal cord, the lesion is probably hitting different networks, sensory networks that are associated with motor function, networks that are intimately associated. So I don't think that we are able to separate completely, but in the majority of patients that I talk about that issue, that symptoms, describe clearly that the banding, the tightness is frequently a sensation of constriction, and in some cases also some painful burning sensation. So I believe that is both. And again, it's because the neurological network is very well associated and working together.
So I never disagree with Carlos, but I might disagree with Carlos. No, so I get the sense that it's more sensory. That's my take on things in the motor, just because it can happen most of the time, and you guys can teach us more about this than anyone. Most of my patients, and I still don't know why, because Doug never taught me, have the banding in a thoracic level, somewhere between the overwhelming majority are between T4, which is the nipple line, down to the mid-abdomen. Why would we not have it in lumbosacral distributions of dermatome or cervical distributions? How many people here have seen a cervical or lumbar banding syndrome? I don't think I've seen it actually. We've got.
I've had feedback from quite a number of people in the support group that claim they've had that kind of a symptom, but in a lower region.
Lower region. So,
I mean, at least a dozen or more. So
in those patients and in the ones we see even in the abdominal, I agree with Dr. Graves in terms of the antiepileptics and certain neuropathic pain medications, but I still have a lot of patients, some of whom are in the room, and I promised I'd push on this issue, who have just recalcitrant banding despite that. And I'm curious with the panel in terms of escalating things. People, they used to do rhizotomies for a lot of different issues, nerve blocks. If you take out the dorsal root ganglion at that level, does it modulate this pain at all? I mean, I don't know, Doug or Christina or Dan?
I mean, I have not done it, but to answer the first question in regards to do we see it in lowers, actually quite commonly, and actually the most significant pain that is really almost intractable to treat are the ones that people have in their groin and rectal area.
Right.
And these are the ones where most people, there's no, in my experience, no drug that works. What I do, sort of, when you ask escalating, there are two ways I escalate. Number one, I go with intrathecal drug therapy. So where you use an intrathecal pump, like we have baclofen with a little small catheter that's feeding pain medication or spasticity medication right next to the spinal cord. And if that's not an option, then the other option that you can do, especially for that level, is epidural stimulation for pain management. So that's probably as extreme as I go, and turns out to be the only thing that really helps. Especially in these lower parts of the body where it's just people can't deal with it. I mean, I have one patient that's almost suicidal from that type of pain.
But you need to make the distinction between transitional zone pain, which is what I believe the question was, versus the central neuropathic pain, which is what you're referring to, because the rectal pain and the groin pain is not at the zone of the lesion. It's 3 or 4 levels below. Or if you have an S4 or 5 TM, you're the only one in this room that heard the one like that.
No, that's correct, yeah. So the lesion doesn't have to be at that level where the pain is. It can be anywhere above it.
So it's a different mechanism of pain.
Are you guys following this distinction? So it's important what Christina's talking about, the transition zone versus below the level. So when you have transverse myelitis at a level of the spinal cord, and again, please, everyone should edit this comment. The majority of my patients who have banding have it near the top of where their lesion was, right at the top of their lesion. So if you're a T5 to T7, your banding pain tends to be right around T5, and it tends not to be an issue at T7, T8, T9, T10 below the, you may be numb below the level of the lesion, but the actual banding, that tight constriction tends to happen right at the top part of the lesion, whereas below it, you tend to have different symptoms. And so there are 2 different types of pain that people can experience. One right at that transition area, which is what Christina was talking about, versus pain below the level.
Well, so I generally start with the regular medication therapies, like nerve pain medications, like Dr. Graves pointed out. But in my experience, most of them are not effective in treating that type of pain. And so then you have to go outside the box. And short of cutting the dorsal root ganglion, which the dorsal root's kind of the input where the spinal cord gets its sensory input, which we have done in the past. At least, well, I haven't, but read about it in books. I don't tend to go that extreme, so that's why I go with intrathecal drug treatment. We take the small catheter and feed pain medication next to the spinal cord, which helps in some cases. Or we use electrical stimulation at the level of the spinal cord, but directly on the spinal cord, which is called epidural stimulation.
For me, I had the band around the stomach, say 15 years ago. I was diagnosed with NMO in 2008, but in 2000 was diagnosed with primary progressive MS. I had symptoms of MS and I guess NMO since 1988. I'm 62 years old. Now I have the pain in the groin area. It doesn't last. It's like a prick. It comes on, it starts, and it just immediately goes away. I don't take baclofen anymore, but were you saying that you suggest a pump, a baclofen pump, or baclofen 10 milligrams, or what were you saying?
Also, what I was suggesting is to deliver pain medication to the spinal cord area with a pump like you would use baclofen. In some patients, and as Dr. Pardo points out, pain and spasticity sort of tend to go together. In the patients that I use that pump in, it's usually a combination therapy of a little bit of baclofen and a little bit of pain medication. It's all together. It's a little bit of a difficult dance, sort of, to find the right dose. So you need a physician who is very familiar with that and who can closely follow you for these.
I'd like to make a comment about that, is that you need to be very careful. Any invasion of your body may bring consequences as well. So the advice that we always provide to our patients is just make sure that you have a very good characterization of the pain, to make sure that the clinician that is evaluating the issue has the right view and make the right diagnosis. It's very different when you are describing this short-lived pain and as compared with a permanent pain or excruciating pain that is going to produce a significant disruption of activities of daily living that may require more aggressive intervention. So that distinction is critical, because you don't want to put a baclofen pump if you really has a pain that is short-lived, happen only occasionally, and is not disrupting significantly your activities of daily living.
Thank you, Dr. Pardo. I think we're going to let you have the last word on that topic, at least for now, so we can move on and touch on some other things. So we received several questions about fatigue, and I think that's an important issue to spend some time on. So the first question in particular, why do some people get fatigue and others do not?
All right. So there are multiple causes for fatigue. So in our population at our clinic, I'll list the top several in close to what I think rank order is. So number one is sleep disturbances of some kind, and it's really fun asking this question in clinic. How do you sleep at night? Dr. Greenberg, I sleep great. Really, what time do you go to bed? Oh, I go to bed at 10. When do you get up? 6. And do you stay asleep the whole night? Yes. You don't get up at all? Well, I mean, I get up to go to the bathroom. Well, how often? Oh, 5 or 6 times. But I go right back to sleep. Mm-hmm. So the problem is, our definition of good sleep is, for your body, 7 to 8 uninterrupted hours of sleep. So if you're not doing 7 to 8 uninterrupted, and uninterrupted means not getting to go to the bathroom, not having sleep apnea or breathing changes, not having a bed partner who has apnea or breathing changes who's keeping you awake, not having a dog or a cat that jumps on the bed, not having a child who runs in the middle of the night, anything that disturbs your sleep, that's a problem. And so for fatigue, we always start with sleep. The next thing for our patient population that we go to is a recognition of a fact that really, frankly, only patients who are going through this truly understand. And that is, for most of our patients, every step they take costs 10 times more energy than every step I take. So if I get up in the morning and I go about my routine to get dressed, if I've had transverse myelitis or NMO or ADEM affecting the spinal cord or my walking abilities, by 10:30 in the morning, I have spent my energy budget for the day. Just by walking through normal activities. And people will sit down and say, well, I didn't do anything. Why am I so tired? You did a hell of a lot. It took you a lot more energy to take those small steps. And so it is just something that weighs down on people, and you get fatigued. The third thing on the list is medication side effects. A lot of medications we prescribe can be fatiguing. And then the last that I find fatiguing is actually pain. In and of itself, hurting takes energy. It's emotionally taxing. And so we try to take a holistic approach to going through those 4 things. So why do some people have more fatigue than others? They may have, at least my guess is, more or less of contributions from any of those 4 factors than others. I don't know if...
I usually throw in depression there as well.
Depression is good.
And there was a follow-up question about mitigating chronic fatigue, and I think we heard some excellent speeches this morning about exercise and physical therapy and strengthening. This particular question is about what else can we do other than exercise, eating right, sleeping right, not drinking alcohol. What else is there? And so maybe one of our panelists could address some treatments other than those mentioned.
So I think first and foremost is what Dr. Greenberg was just talking about, making sure that it's not something else going on. Is it sleep issues, depression, something else that we need to treat primarily? But if we're left with addressing those things, or we can't avoid certain medications that are creating some of the drowsiness, then there are medications that we use for fatigue. In my practice, I usually start out as simple as an over-the-counter supplement called L-carnitine, which is very safe, and there's some studies suggest that it helps with primarily more mild to moderate fatigue. And then from there, I'll go to medicines like Provigil or Nuvigil, which can be very helpful, but sometimes difficult to get the insurance to pay for. And then even using stimulant medications like Adderall, Vyvanse, these types of things. So there's a number of options that we can use.
Hi, my name's Mary, and my question is that I still have no sensation from the right groin down to my foot, and during physical therapy over the last 6 months, I've had an avulsion fracture of my right hamstring and strained my right calf. And so it's hard for me to want to exercise and in physical therapy, I'm scared that I'm going to get hurt even more. And, there's no boundary for that leg because I can't feel anything. What advice would you have for my therapist, or for me even?
Well, I'd be really interested to know how you ended up with those injuries.
The hamstring, I was just stretching.
You must have really been stretching.
And I felt a pop in my hip, and I go, wow, I can move my leg better now.
It's dangling.
I didn't know.
It's moving very
I didn't know for 3 days till the black was on the back of my leg. And then I went to the doctor, and they did an MRI. I didn't miss a day of work. I was in physical therapy. There was a lady right next to me with the same injury in a wheelchair.
So what other kinds of things are you doing in therapy?
Well, from that point on now, it's been a little more simple. But I'm also a tennis player, and I love to play tennis. I'm really tired of being told, don't do that, you might hurt yourself.
Well, I don't know what I think there's a couple of issues. Number one, I'd really caution you about how you're stretching, because you've got to really be stretching like a maniac to create that kind of an injury. The other thing is I would again caution you about playing something like tennis if you have no feeling in your leg. That's a recipe for disaster. Because if you can't feel your limb, then you don't know if you've turned your ankle over. You don't know what position your foot is in. I mean, you just have to be really cautious with things like that. I mean, I would definitely scale way back and start with activities that were much more controlled, like an elliptical, where your feet stay on the pedals, You're going to have to really grade that stuff. Obviously, now you're going to have to heal. But you really need to be cautious about the kinds of activities that you're doing, particularly if your sensation is that profoundly impaired. I mean, you may need some sort of orthosis, something to protect the stability of your ankle, those kinds of things, because you're going to always be set up for injury. The reason so many of our patients have so many problems is their sensation is so impaired. So you have to always be thinking about what kinds of activities can I do and still protect the joints and still keep you stable, because it's our first line of defense. Your sensation from the ground up tells you where you are and gives you, am I stepping in a hole? Am I stepping on a rock? So, I mean, again, without knowing more than that, that's the first thing I would say is I would really be cautious about the activities that you're doing.
And if I can add to that, so the other thing that might be more comfortable for you is to maybe do some things in the water where you have consistent resistance but don't have gravity to deal with quite as much. But I also would caution you, don't just do nothing. That's the worst solution. Even though it might feel the safest, you really want to make sure you're in good hands with the physical therapist that understands how this happened and have a plan that you understand and you have some feedback to offer. What I keep hearing, if I can sort of take from that comment, is that a lot of people here seem to feel like that it's frustrating to go to physical therapy because they may not understand the issues. So I'm wondering if it would be of interest to others it seems like we have kind of two centers that seem to have a lot of resources, a lot of knowledge about this. There's the Baltimore group and then there's the Dallas group. So I wonder, would it be of interest to have some kind of training session to try to invite other therapists to learn about this that are outside of our two little communities?
Actually, KKI has seminars throughout the country doing ABRT. Right. Seattle, Washington, Boston, Virginia, The next one is in Tampa. There are 2 or 3 day seminars in which we instruct, therapists instruct therapists about how to deal with activity-based. So Tampa is February. Oh, Nashville just happened last month.
But to add, so not just about a particular type of therapy, but to understand the disease and how the disease relates to
this is
the
neurorehabilitation now.
Would be right.
Okay, so there are some resources there. Perhaps I'm sure there are internet resources as well, because even with many like in-person sessions, we're not going to be able to reach everyone. Right. So, but I think I'd like to maybe set that aside, and we can find a way to get some internet resources available for people who have had similar issues. But I would like to sort of segue on something that we heard from Karen McCain just a second ago, and this is a question that we received. My balance is poor, but all the tests say I'm fine. Why is that?
So my question would be, what are the tests? So again, what kind of tests, if anybody has some input who wrote the question? There's instrumented testing, there's clinical-based testing, and balance is one of those extremely complex things. There are many, many things that go into controlling your balance. Your sensation is just one of them. Strength around your ankles particularly is extremely important. So it's a little bit difficult to answer the question. And again, I would ask, what kinds of activities are you having difficulties? Where do you have balance problems? Is it when you're walking? Is it when you're doing transitional movements? Those kinds of things, because those are the things that direct a treatment plan. We have lots of patients who have tendencies to fall backwards. So we have to address that as an individual problem. It's a little hard to answer a total question about balance, except to say that there are many, many parts of it. So your therapist needs to look at all of the components that can go into balance. It can be an inner ear problem. I mean, it could be a dozen things that are causing a balance impairment. So you're going to need to be extremely specific with a therapist about where your balance problems are. If they say the tests are normal, then you need to explain to the therapist what the activities are that you're having difficulty with, so that they can devise an appropriate intervention.
I think we have another question over here.
Hi, my name is Priscilla, and my question is actually for Dr. Levy, is it, or Levi? I'm already taking forminoperidine. I've been taking it for about 2 years. I take 30 milligrams a day, about a 5 milligram pill every 3 hours. So since I already know it helps me, would I even be a good candidate for your trial?
You would be excluded because we don't want to know in advance if it works for you. We want to know if the drug compared to placebo is effective. So, but the really important thing is that it works for you. And if you know that when you stop taking it, it doesn't work as well, then you already have the answer.
I have a cognitive question for Dr. Harder. I have a daughter who has severe cognitive deficits. Most of you have met her. Is there anything I need to look out for as she hits puberty and continues to develop cognitively as a result of TM?
Could you say a little bit more about severe cognitive deficits?
Sarah was born with microcephaly with simplified gyral pattern. She's nonverbal. She has seizure disorder. She didn't walk cognitively till she was 38 months the first time around. Her onset date was November of 11, so we're almost 2 years. She's 12 now. Okay. So my question is, as her hormones change and as puberty comes, am I worried about additional cognitive deficits caused by the TM?
I am unaware of any hormone-related changes that we might expect related to cognition. The people that know her best are the ones who are in the best position to monitor that. So looking for changes over time and tracking those may be the best that we can do to sort of see, compared to herself prior to puberty, how does she look across time, and then how would we address that, depending on what shows up.
But can I change the question just a little bit, because I'm curious? Do you expect for the cognitive deficits that you've seen in the TM population to be a static one-time change and then people go on with development at a normal rate? Or are you getting a sense it changes things from that point on?
So we don't have those answers yet, but that's what we're hoping to look at in our longitudinal data. But this question is complicated, by the developmental context that you describe.
Okay, I see a question over here in the back.
Yes, so far today we've talked about, as far as strength training, we've talked about as far as a little bit of aquatic training. Has anybody seen any studies or research as far as on the possibility of, say, isometrics training or, say, negative resistance training for somebody that actually can't control their muscles that well? Or the possibility of, say, Tai Chi or Qigong for balance? Any comparisons?
I will tell you, I have not read studies about those particular techniques, particularly with patients with TM. I will tell you that what we have found over time, when you look at the sort of concept of specificity and the importance of strengthening in the context of the activity, and seeing that we treat primarily patients with neurologic impairments who have gait disorders, we have found across the board, without exception, that they do the best if they do the functional activity. Isolated, strengthening kinds of things, there is a place for strengthening. There is a relationship between impairment, like weakness and pain, and function, but that relationship is not direct. So strengthening doesn't necessarily mean that you will improve function. It's obviously a piece of it. If you're so weak you can't stand, then clearly you're not going to be able to walk. But we've found over and over and over that the most effective strengthening is done in the context of the specific task that you want to do, which is why when we advise our patients, just like Dr. Greenberg said, by 10 o'clock, my energy reserve is gone. So when we advise our patients to exercise, most of them don't go home and go to the gym and work out hard on the weights for 20 minutes and then hit the treadmill for 30 minutes. They can't do that. So we say prioritize. And the first priority, if your task is walking that you're interested in, is walk. That has to be your top priority. It has the best potential. Now that's again why we want you to get you to walk as typically as possible. Because we've also found that if you're walking with atypical mechanics, then you're not using the muscles the right way and the muscles are probably going to become weaker. If we just get you back up to the right kind of walking, the muscles have the best opportunity to strengthen appropriately. So for example, if you have a weak calf and you hyperextend your knee, which is the primary reason why you hyperextend, if I continue to let you do that, you're just going to continue to get weaker and weaker. I have to stop that maladaptive pattern to be able to try to reverse that strength loss, if that makes sense. So at the end of the day, we tell patients the same thing. Walking needs to be your top priority, but it needs to be good walking.
If I can just add to that, there are other populations where they've really emphasized, we talked about this earlier, they've emphasized this. So in Parkinson's disease, for example, they've found specific kinds of dance and yoga have been found to be really effective. So I think the caveat to doing walking, because that's the most direct thing that will improve your walking, is that if you need to exercise and you can't walk somewhere, but you have an interest in these other types of exercise, then I think you should do that too, because that keeps you stronger. That would affect your fitness overall, probably will affect your walking. It's not as direct as just practicing walking, but the reality is doing something consistently over years is really difficult. So if you like to do one kind, adapt it, work with a therapist to adapt the task that you're interested in. And if it's Tai Chi or any of these other martial arts, I think that's something that could be adapted and would be useful.
Okay. Sorry, that was Professor Graham Martin, who got TM in 2009. He's a psychiatrist from Brisbane. He has embraced martial arts in various forms for the last 40-odd years, and he teaches children at risk and enjoys it, and he participates with his family, and he practices meditation. And he's found that part of his recovery has been that it's assisted him so much in refocusing on it. He said he's had to adjust, but he has a blog, an ongoing blog. He also has a book, which I can give you information about if that's of any interest to you.
Okay. We received several questions for Dr. Becker about FES. The first, has FES ever been used for bladder control for people who are still catheterizing?
So this is actually, FES came in the, has been out for several decades. And so some of the earlier FES devices were implantable, and there was what's called the Vocare bladder system, which was combined with a dorsal rhizotomy, kind of where you cut the nerves as they go into the spinal cord. That's the only one I'm aware of for bladder function. But that system is not being used anymore. There were too many problems with it. I think there might be something in sort of a resurrection of that, maybe down the road. As we all had moved away from implantable FES systems, now I think there seems to be a trend, at least in Europe, where we're going back to implantable FES systems as technology is improving, as materials are improving. But yeah.
Okay. And then we heard a little bit about the interstim, which is a different but perhaps related technology. But also on the topic of FES, do you see FES being useful to those who have more sensory impairment, like in Asia category D, versus those who have more motor impairment, A through C?
Yeah, I mean, that's a definite yes. So when we look at the way we activate the nervous system with functional electrical stimulation in our spinal cord, each function sort of runs in a different highway. So, there's a highway for motor strength, there's a highway for balance, there's a highway for light touch, there's a highway for temperature and pain. And so when we feed activity into that spinal cord and activate these small little computer algorithms in there, for example, the CPG, they all communicate with other centers within the spinal cord. So by activating, which appears to be a motor nerve with functional electrical stimulation, we also activate some of the sensory pathways. And we believe that the way you activate sensory pathways, they can also be repaired at least as good as the motor pathways. So FES is, I don't think, very specific to a certain pathway by itself. So I think we hit everything with that. So that includes sensation, that includes bowel and bladder, and including sexual function.
Okay, thank you. All right, any questions in the audience? Yes, in the pink.
I'm a little confused. I'm concerned, first of all, with several, they all kind of come together. We talked about fatigue and exercise, and my question would be, if you are fatigued, can you exercise to build up a greater reserve of energy? Will that help you eventually if you have a program you follow and get continually more aggressive with it, possibly? Is it possible to do that?
Well, so I'll give a short answer. I think it'd be good to get multiple comments on this. The analogy I use in my clinic is to a household budget. And so Congress hasn't figured this out, but everyone else has, that there's income and spending. And there's different kinds of spending. Sometimes you're taking money out of your budget to build savings and earn dividends. And so regular cardiac exercise I view as one of those plans. You have to spend a little money, put it in the account, but ultimately you may earn interest on it and expand things. But there is, and this is where I'm going to turn things over, I'm sure it can be overdone. You can put away too much money.
But you can't build up your reserves. You're saying you have X amount of energy and that's it. You can't build up a greater amount of reserve. You cannot get yourself so you can do more.
No, you can. So what are the ways you can build up a greater reserve? You can make sure you're getting good sleep. I think diet goes a long way. What we eat makes a huge difference in terms of how we feel and what our energy levels are. Watching out for things that are an energy suck, where you're just wasting spending and getting rid of those. But on the income side, I think exercise, diet, and regular sleep are my top three for building more income, if you will.
And then to tie it to Dr. Becker is exercise, physical exercise, similar in this, doing the same type of things the FES does? When you talk about exercising and how it helps the spinal cord and the regrowth or regeneration?
Right. So exercise itself is very good because it feeds activity into the spinal cord. It always depends on what is your level of function. If you can't, for example, you have a paraplegia from your belly button down, and you have no motor function in your legs, there's no way that you can at least voluntarily activate this part. So you actually need the FES to do that. In the more incomplete type pictures where people have some function, exercise is good. But we have seen in the studies that we're doing that if you combine exercise with FES, you get much more results, much more bang for the buck, right?
Can I add something? So the other thing is, I think a common misconception is that I want to exercise, so I just start exercising and do 30 minutes because that's what the Surgeon General says everyone should be doing. But the reality is you have to decide for yourself, or with the help of a therapist, sort of how much you can do and gauge how you feel the rest of that day if that was too much. And I really, really advocate for having some kind of systematic way of increasing how much you do, because it's really easy to lose track of it. And to be, I feel really good today, I'm just going to do twice the amount, because there really is, you do have a certain amount of energy, and where, when you're younger, you have more energy, and then as we age, you have less energy. So in addition to any condition that's added on top of that, we have aging to deal with. So I think it's just more of a being systematic and regular about how you're exercising is the way you're going to build up more of a tolerance and to have more energy.
Okay, any other questions in the audience? Okay, over here in the back.
I have a question because I've been dealing with chronic fatigue or Epstein-Barr since '88, and it seems that this particular transverse myelitis that I was diagnosed in just this past July seems to have some commonalities in with this. And wouldn't it be advantageous to see some kind of talk about stress and how that relates to the body? Because I find that if I'm under a tremendous amount of stress, I generally have a little bout of chronic fatigue. I've had a tremendous amount of stress over the 2 years, and I'm trying to figure out how I got this transverse myelitis, and I'm thinking maybe this might be a part of it. And I'm thinking maybe in your group here, maybe a talk on is somewhere down the road on stress management would be helpful, at least to me, maybe some others in the group, that so we can get some ideas on how to handle that. So if anybody has any ideas on how to handle stress today, I'll take it. Thank you.
That's a good question. Your situation sounds a little bit special, a little different. But I think the broad question of how does stress affect transverse myelitis is really important. So is there anyone on our panel who wants to address that or share experiences?
They're fighting over it.
Okay.
So you're talking about stress, and they all turn their heads and look at me. And, I mean, yeah, I had a little bit to drink last night, but that's not my stress coping mechanism usually. So there's two parts to your question, the way I hear it. So one is on stress as a trigger for events and can it lead to events, and the second is on chronic management of stress and how it leads to symptoms and how we feel. So separating them out into those two categories, we have really crappy data around the notion of stress and inciting events, because the problem is we all rate stress differently. So if I turn to Sandy and say, Sandy, are you stressed today? He always says yes. He's, and except on certain days when Symposium's done, on the last day he says, no, I'm not stressed today. And we all kind of rate it differently. The one study that I know of that has looked at stress and autoimmune events of the central nervous system was a Danish study, I think it was Danish, that looked at, they sat around and they said, well, what's the most stressful event a human can go through? And they picked it. It was loss of a child. Okay, so we can all agree that that's the penultimate. You can cause me work stress, you can lock me in a room with Doug Kerr for a week, you can do all sorts of things, but that's it. And they actually looked at first events and relapses of multiple sclerosis. And in the year following loss of a child, there was a higher rate of first events in the parents or relapses of multiple sclerosis. So there is some data to say, and there's plenty of basic science data to say, that stress has an impact on the immune system. It can rev things up. So have we proven stress relative to transverse myelitis? I know of no studies or analysis looking at it, but we can't, when we look at chronic daily stress, we don't seem to see an association, but it's not an easy study to do. On the symptom management side, we absolutely see an association between stress and how people feel. And so as people are stressed, the way I think about it, and I could be wrong, is if your body's living at an adrenaline level equivalent to running a marathon, and yet you're sitting at work, your body gets the sense you're running a marathon, but your mind says, I'm just sitting at work, and there's a disconnect. And those physiologic changes that come with stress can amplify everything. They can amplify pain, they can amplify fatigue, amplify depression, they can present with anxiety attacks, all sorts of things. And so stress management is incredibly important, at least from my point of view, for the daily management. And there's lots of ways to develop coping strategies. Part of it is figuring out what stresses you out and seeing if you can be proactive about it. finding an outlet, and I defer to the panel, but I actually think regular exercise turns out to be probably one of the best stress managers, because if you burn all of your adrenaline in the pool or on an elliptical, there's less to burn through when the person at work is a jerk to you and would get you stressed. And some people find an outlet through hobbies, some through spirituality, through faith. There are lots of ways to try and find that peace. Yoga is a great way to relax, and you get a twofer stretching. And I mean, Janet, I don't know, I know you counsel patients on this a lot. I don't know if you want to add to that.
No, I leave that to the behavior psychologist.
But in a way, it's funny, we've all become behavioral psychologists. I mean, we have this conversation a lot. I know we're really not. I'm not encroaching in psychology. I'm going to get yelled at by the psychologists. But I'd say it's very important, and pick a intervention strategy from that list. Start with one, work it in, and really try and get an assessment of how it impacts your well-being and your outlook. So,
the other thing to add to that would be a careful assessment of kind of social support, friends, family, whatever it is that gives you support in your life, in addition to what Dr. Greenberg said. And there are psychologists that do just this work and help break all of those things down and decide where to start and how to prioritize to, put you in a situation where you can manage stress the best, enhancing coping mechanisms, things like that.
I was going to add to just, I think it's a problem for lots. It's a common problem, and I think having a little bit of trying to sort of sit down and have a little introspection on what you think you enjoy the most is usually the thing that gives you the least amount of stress, and then try to remember how that feels, and that's part of the whole sort of meditation going. But so I think there's a lot that's at your fingertips that could help with stress relief. It doesn't need to cost a lot of money. It's more of you have to kind of think about for yourself what makes the biggest difference.
Hey, my name is Sharon, and I had an onset of this on May 10th, 2012. And I wanted to ask the panel what you think about taking vitamin supplements, if that helps in any way. And also, I have gone to see a different alternative type of a doctor, and he recommended amino acid injections. And I wanted to see what you thought about that.
All right, do we have a specialist in complementary medicine?
So I'll comment on the vitamin question first. So most of this is actually taken from data that we have about multiple sclerosis, with it being more common, but I think it really applies to all autoimmune diseases. There's numerous studies to say that vitamin D is beneficial in autoimmune diseases, and that we really need very high levels of vitamin D for that effect. So the key is getting your vitamin D storage levels up. So it may mean varying doses that you require. That's really the primary vitamin that we have good evidence for. There's also a little evidence for omega fatty acids. There's some studies to say that it's helpful in autoimmune diseases. Others say it's neutral, but that's another one that I discuss with patients. There's really no evidence for using, super doses of other vitamins. A lot of people like to take B-complex vitamins and things like this. The truth is that primarily you excrete these if you're taking too much of them. So I recommend a multivitamin, vitamin D, and then omega fatty acids. And I really don't have any evidence, although I don't know a lot about the amino acid infusions. I don't know if somebody else has more.
The other vitamin that is extremely important is vitamin B12. And we always teach the health practitioners, medical students, and everybody involved with medicine that vitamin B12 deficiency may mimic a lot of neurological problems. And every time that the patient comes to be evaluated for any type of neurological problem, including transient myelitis, we need to be checking vitamin B12, because that's very easy to treat and it's very easy to fix a problem with vitamin B12 deficiency. On the amino acids, there has been a lot of noise about amino acids, but I don't think that there is a real proof that taking amino acid in indiscriminate approach is going to be helping. It may help if there is demonstration that there is a nutritional deficiency or any underlying mitochondrial disorder, and we introduce here a term that may be a little bit difficult, but mitochondria is a part of the cell, that is the battery of the cell. And in the past several years, there has been a lot of interest on the mitochondria function because that is critical for maintaining energy in the cell. Empirically, a lot of people are jumping to give amino acids to patients with the assumption that that is going to improve energy. And I think that that's wrong. We use amino acids only if we have a proof that we have an underlying metabolic problem. And the concern about using mega doses of vitamins is a very important concern because some vitamins actually may be toxic. The most frequent one is vitamin B6. And people abuse vitamins and occasionally get very high level of vitamin B6 that is toxic and produce peripheral neuropathy. So on advice of multivitamins, you need to be extremely careful.
When you talk about people taking vitamins who have an autoimmune disorder, that there is some evidence that there are certain things that are beneficial. After a person has had that demyelinating attack from idiopathic transverse myelitis, do they have an autoimmune disorder? And would you look at that, would you look at that those health issues in the same way that you would with a person with multiple sclerosis or lupus, or where they're at risk for another attack? I mean, does that make sense?
No, not well. So the way I interpret the question is, so if you've had idiopathic TM, which we define usually as a one-time only event, do you have systemic autoimmunity that requires these types of interventions? Is that fair paraphrasing? So there's two answers. At least I have two answers. I'm sure actually there's 20 because it's two each. And so we'll get 20 different answers. So answer number one is it's only idiopathic one-time only TM in hindsight after many years of making sure it doesn't happen again. And so idiopathic TM is still a mixed bag. Some of it is post-infectious or para-infectious. You get an infection, your immune system gets confused, fights it off, and it's never going to happen again because it was an alignment of the stars. But your immune system had the potential to do that. It had the capability to get confused. So in general, I still say do the things like vitamin D, and it was Mike and Maureen with data from other centers who put out the first paper on vitamin D and transverse myelitis, saying that people who were vitamin D deficient, I'm paraphrasing, had higher rates of recurrence in the future. Now, were they, or were at risk, or people with recurrent disease had lower vitamin D than idiopathic? I'm getting it close to right. And so, in general, we still say go on vitamin D because I think it's safe, and the normative values that are in the literature, just so everybody knows, and we're talking about D3, not D2, is based on preventing rickets. That's where we got the normals. Well, if I open a bottle of vitamin D in the room and everybody inhales deeply, you won't get rickets. It takes just a little bit of vitamin D to prevent rickets, but that's where we define normal from. And it's only in the last 10 years that we've started to redefine what normal should be relative to other health effects. And so we, I think in general, are underselling ourselves on the vitamin D side of things.
Let me just add to the vitamin D discussion here. I think it's really important because what we found is that patients with TM had normal vitamin D levels when they got their disease, whereas the people who had recurrent disease, TM over and over and over again, those people had low vitamin D. Now, I'm not saying that if you correct your vitamin D, you're not going to have any recurrent disease, but I would say that there's almost no toxicity to vitamin D, and you should really try to bring it up to a normal level, even if you think you just have TM1, monophasic TM, idiopathic, because there's really, it probably has more benefit than harm, and everyone is pretty much sun deficient in the United States, and so even if you're healthy, I know my wife, when she was pregnant, tested low for vitamin D, and they pushed vitamin D on her too. So many other conditions than just autoimmune diseases.
If you are not a member of the Transverse Myelitis Association and you're sitting in this room, you need to join. And all you have to do is go to our website, www.myelitis.org, click on Become a Member, and fill out that trait-wise form. It's really important to do that. If you are a member of the Transverse Myelitis Association and you have never gone to that trait-wise form to fill out the information. We really need for everyone to do that, because it is ultimately a very powerful tool to help us educate the physicians about what's going on with these disorders.
Sorry. Okay. This is for Dr. Harder. I'm actually a teacher, and my husband has transverse myelitis. And so one thing I have noticed, being together almost 10 years, but 3.5 years of him in this process, is it has greatly affected the cognition. And as a teacher, I take great interest in that, but I've noticed that he's been trying different classes to go back, and he has to work so hard to get it from that working memory to committing it to long term. And so like he records things, he writes things down, he'll replay it, he'll retake notes on top of notes. I mean, Cornell notes got nothing on him. But there has to be something that I'm overlooking, or I'm a teacher, I'm an elementary teacher. So there has to be something to help him commit things to long-term memory, because it's just like he's had a memory wipe. And I have to remind him of things like our first date and that kind of stuff. So, sorry, but there has to be like something to kind of better access long-term memory, or to help bridge those neurological connections to make those long-terms actually stick.
And this is a great illustration of how cognition can actually impact a family system or relationships, and I appreciate you sharing that. Also want to note, we can speak, one-on-one a little bit later about the specifics. As we noted earlier today, so many of the interventions are really tailored to the person. So, my first suggestion would be a thorough, comprehensive evaluation by a neuropsychologist to really tease apart what are the deficit areas, and importantly, what are the strengths, right? Because any of us taking a battery of tests would have both. And so we need to learn how to maximize the strengths to address what you're describing. And a significant other is a great source of information as we undergo the evaluation process. So from there would be things that could be designed that are customized to help. You mentioned school. Is this college courses? So the other thing to know is Americans with Disabilities Act does cover folks with cognitive deficits in a college environment. So there are lots of accommodations that can be provided. I'm not sure if you're plugged into that, but a neuropsych evaluation would give you the documentation you need to access that kind of support. But again, I'd be happy to speak with you guys a little bit more as well.
Thank you, Dr. Harder. And we have one more question over here in the back.
Yes, my name is Paul Eicholtz, talking for my wife, Stephanie. She was diagnosed this year with NMO. Prior to that, we were stationed in Sicily in 2000, 1999, 2000, somewhere around there. And I think that was her first onset of the disease. She had an episode where she became wheelchair bound for about 3 months, and I had to push her around. We were flown from Germany to Walter Reed. We spent a month in Walter Reed, and the neurologist there did all the testing. Really couldn't determine anything other than that she did have neuropathy, and definitely had some problems in her lumbar region. Then miraculously, she got better. Everything returned to normal. From then till now, she had several reoccurrences of lumbar problems, the crushing pain, banding that we were describing earlier. Things like that. But my question is during all this process, she had several treatments that were designed to treat what I would call the symptoms of what was going on and not the disease. She had a neuromodulator installed in her spinal column to stimulate for pain management more than anything. And of course, during that from 2000 till now, she's had multiple treatments of steroids into her lumbar region, again, for pain management and to restrict the inflammation. Do you think those treatments aided in kind of reducing the amount or the frequency of episodes and kind of help to control the disease?
Okay, Dr.
I'll try to take this one. For NMO, really the best preventive treatment is suppressing the immune system. Steroids do that. but it would have to be on an ongoing basis. There are many other better medications than steroids to use on a preventive basis. We don't know any of the other real triggers, as Dr. Greenberg mentioned. We don't know cheeseburger versus vaccine, what stimulates an attack. We do recognize that activating the immune system is probably not a good idea. So acquiring infections, if you move to a new place, you may be susceptible to those viruses. That can trigger attacks. But again, the best approach for NMO is, on the one hand, preventive with immunosuppressants, and then on the other hand, symptomatic management with things like epidural injections or spinal cord stimulators or whatever else you need to control the symptoms.
Okay, we are out of time. I would like to thank all of our panelists. Thank you.